is Christina Bokat. I am a physician who works over at the headache clinic, one of the physicians that works over there. But full disclosure, I am not a neurologist. I am actually a chronic pain doctor. I did my training in anesthesiology and then I did a year fellowship in chronic pain. And then I really enjoy headaches. So I work over at the headache clinic 1 day a week. Most of my time I actually spend over at the pain management center, which is very, very close. And so I'm going to talk to you a little bit today about some procedures we do to treat headaches. There are lots of different procedures we do over at the Pain Management Center, but I'm going to try to limit the talk today just about what procedures we do, both myself and some of my other colleagues at the neurology clinic there. So I'll try to keep this short too, so that you have time to ask any questions you might have. Let's see here. Okay. I'd say that probably the most common procedure that we often do is Botox. Botox has been FDA approved for chronic migraine specifically for a little over a decade now. It's been around for decades before that, so it does have a very good track record for safety. Excuse me. It is a botulinum toxin. It is mainly very similar to what people get for cosmetics as well. But again, it is FDA approved for chronic migraine, meaning it's not a weird off-label use. So in order to qualify for your insurance to pay for Botox and to be covered for chronic migraine, you have to A, meet the diagnosis of chronic migraine. And what that diagnosis actually means is that you have at least 15 headache days a month of any kind of headache, and about half of those, so 7 or 8, are migraines. They also usually want you to have tried at least a couple of the oral preventative medications before they'll approve it. And everyone's insurance is a little bit different. So if you do have occasional migraines, maybe 1 a week, 2 a week, and not a lot of headaches in between that, you may not be able to qualify. So there are certain, I guess, hoops you have to get through in order for your insurance to approve it. We do Botox once every 3 months. And basically all of the evidence for it is based on the PREEMPT trial, which showed that Botox was helpful in reducing the frequency of migraines. They set out a pattern of 31 different spots all over the forehead, sides of the head, back of the head, top of the neck, and shoulders here. So it is a lot of different spots there, but we're usually done very quickly within 5 to 10 minutes. It's a very small needle gauge. It's analogous to the needles that they often use for acupuncture, if you've ever tried that. We are injecting that botulinum toxin, about 5 units, into each of those locations there. Really very few risks overall. We always have to tell you there's a risk of bleeding or infection. That's pretty rare. There's sometimes the risk that you can get a droopy eyebrow or potentially some neck weakness, but again, those are usually pretty rare. You may find that your provider might slightly alter where they put these injections. They may do more or less, kind of depending on you and your headaches. Often people may not notice a huge difference the first time we do the injections. Some people do, but not everyone. More commonly, you start noticing that benefit the second time we do it, so 3 months from the initial one. And then usually you maximize that benefit the third injection, so 6 months from when you first start. Still usually have to keep getting it, but kind of as good as it gets that third time is what you anticipate moving forward. We don't actually know how Botox works for chronic migraine. It paralyzes the acetylcholine that gets released at the neuromuscular junction. So that's what gives you that kind of paralysis and takes away any potential wrinkles there. But for the actual migraine part of it, we're not entirely sure. So I'll move on. Another excuse me, potential procedure we do is one called occipital nerve blocks. So you have a greater occipital nerve that comes out of the base of your skull, and it travels up and around to your forehead or behind the eyes there. Sometimes that nerve can seem to get inflamed for a variety of reasons, whether it's prior surgeries, car accidents, whiplash injuries, head injuries, potentially a lot of muscle tension can press on those nerves. So sometimes your physician may recommend, if you have kind of that typical pattern of pain that comes up and around, doing an occipital nerve block. These are usually done again in clinic, takes less than 5 minutes. We often will inject a couple different things. Often we'll do a local anesthetic, and that can provide some numbing from anywhere from 2 to 6 hours. Interestingly, sometimes even just that local anesthetic seems like it could potentially get you a little reset of that nerve for up to 2 weeks. Sometimes we may also inject a little steroid. Sometimes that seems to buy a little extra time. That steroid can usually be injected every 3 months. So sometimes that might be a good option to add into there. Your doctor may decide not to if you have certain conditions like diabetes or don't do well with steroids, whatever the reason is. And sometimes this can be used in conjunction with other procedures. Sometimes if that Botox wears off like it normally does around 10 weeks, sometimes it may be helpful to do an occipital nerve block to buy you a couple extra weeks when that Botox is worn off. Very, very low risk overall. The other procedure we often will do is trigger point injections. And these can be done for a lot of variety of different headaches. Typically, we do it if we think there's a strong musculoskeletal component to your headaches. So whether that muscle tension is contributing to tension headaches, or potentially that muscle tension could be contributing and causing some migraines too. Sometimes we can either recommend physical therapy or potentially these trigger point injections. And what we do here is usually find those areas of pain. So if you can press down and find the area that recreates some of your headache pain, we can inject a little bit of local anesthetic within that, I'll say, trigger point or not there, to try to get those muscle fibers to release and hopefully stop contributing to so much of your headaches. One of the interesting things about myofascial, or this muscular-based pain, is that it does radiate or spread out from that one location. So if you see in this picture here, the X's are where those trigger points are. So there's a muscle in your neck called your sternocleidomastoid that kind of runs from behind your ear down to your collarbone. And often if you press on that and you do have trigger points, not only can it hurt there, but it can actually spread up and around your eye here as well, and some to the back of your head. And you can also have some trigger points in your neck that spread up the back of your head. So a lot of times, even though it's muscular, it can spread almost like people think it's a nerve-based pain, but it does have those traditional referral patterns. So there can be lots of ways to treat this, like I said, rather physical therapy or potentially these trigger point injections. And then probably one we don't do quite as often, but are able to do, is something called a Sphenopalatine block. Sphenopalatine is a basically collection of nerves that sits at the base, kind of behind your nose there. And sometimes, especially if people have a lot of pain, they feel kind of behind the eyes or behind the nose, what we can do is a Sphenopalatine block. Now, there's some couple ways of doing this. There are some really fancy ways that involve x-rays that are kind of beyond the scope of our clinic. But one way is to take a very long, basically Q-tip, and you can dip it in what we call viscous lidocaine. It's kind of almost like a syrupy consistency of that local anesthetic, that lidocaine. So you put it in there, and then you have the patient lay down with their head slightly extended, and you put this Q-tip basically back until you get to that sphenopalatine ganglion. And it is always a little surprising when you see exactly how far that Q-tip can go in. Then you have a patient lay there for around 10 minutes or so while that Q-tip kind of lets that sphenopalatine ganglion absorb that local anesthetic that you coated the tip in there. People tolerate it better than you think they would, but it's not the most comfortable thing. Sometimes, again, you're just putting in that local anesthetic. So theoretically, that's only going to last several hours. But sometimes it seems like it's almost like a little reboot, kind of like that local anesthetic we put around the greater occipital nerves. It seems like a little reboot for your brain to try to get you out of that headache cycle. So these are all potential options, kind of depending on what type of headache you have. There are some other specific nerve injections that we can do potentially in clinic. I didn't bring those up because they're not quite as common and they tend to be more specific for potentially some different types of neuralgias, as we call them. But I think those are the most common ones that most of us will do. And most of the providers do most of these procedures. Sometimes it is possible if you have a provider that doesn't do them, they may refer you to some like myself or some of the other providers there that do more of these procedures. But I think that's all I had actually prepared. So Nellie, I am totally fine if you want to open